Hi everyone, welcome to our module on metabolic alkalosis. So let's review the four classes of acid-base disorders. There are the respiratory disorders, which I talk about in a separate module, and then there are the metabolic alkalosis and acidosis disorders. And in this module, we'll talk about the metabolic alkaloses. So a metabolic alkalosis happens when you get a high level of bicarbonate and the pH rises to be greater than 7.45. And remember that all acid-base disorders are easy to understand if you know the acid-base equilibrium equation. So anytime there's an imbalance in this equation, the body will try to correct it. So if you have a high level of bicarbonate, the body will drive the equilibrium this way to try and bring that bicarbonate level down. Driving the equilibrium this way will reduce the amount of H plus atoms, and that means you will get a high pH and an alkalosis. So there are six major causes of a metabolic alkalosis, and I've listed them for you here. A contraction alkalosis is the one you're going to see most commonly in the hospital. You can get a metabolic alkalosis from hypokalemia, from diuretics or vomiting, from high levels of aldosterone, and finally a very rare and unusual cause is overuse of antacids. And all of these cause a metabolic alkalosis because the body either loses H plus or gains bicarbonate. So the first cause of a metabolic alkalosis that we'll talk about is a contraction alkalosis. And this is what occurs anytime there's a decreased effective circulating volume in the body. That's why it's called a contraction state, because there's a contracted circulating volume in the body. So contraction of the circulating volume leads to activation of the renin-angiotensin-aldosterone system. This has several effects which cause the pH to rise. First off, hydrogen atoms are secreted more in the proximal tubule due to angiotensin II. As a result of more hydrogen atoms in the proximal tubule, you get more bicarbonate resorption. We'll talk more about that in a minute. And then finally, in the collecting duct, you get more H plus secretion as a result of aldosterone. So let's review what's going on in the proximal tubule that can lead to a contraction alkalosis. Angiotensin II is going to activate this protein right here. That's going to cause more sodium to be reabsorbed in exchange for hydrogen atoms. These hydrogen atoms are going to combine with bicarb to turn into carbonic acid. Carbonic acid will be converted into CO2 and water by carbonic anhydrase. These molecules can then diffuse into the cell, and then once again carbonic anhydrase will convert them back into acid, and then they'll fall apart into a bicarb molecule and an H plus atom. That bicarb molecule will then be resorbed. So the net result is that the stimulation of this protein by angiotensin II leads to more bicarb coming back into the blood, and that is part of what gives you a contraction alkalosis. In the collecting duct, aldosterone has a number of effects. It's going to promote the resorption of sodium and the excretion of potassium, but also in the intercalated cells, it promotes the excretion of hydrogen atoms, and this is also part of what leads to the contraction alkalosis. So the next cause of a metabolic alkalosis that we'll discuss is hypokalemia. So recall that potassium ions can exchange with hydrogen ions and shift in and out of cells in the body. So when you get a low level of potassium in the blood, potassium will shift out of cells in exchange for H+. So the H+ will go inside the cells. This will result in a low level of H+ atoms in the plasma, and this will result in an alkalosis. So essentially, hypokalemia leads to an alkalosis. Now the reverse is also true. So if you happen to have an alkalosis for any reason, you may see low potassium. More often, the alkalosis causes the hypokalemia, but if you do get severely hypokalemic, that can also cause an alkalosis. The two tend to go together. Diuretics are another cause of a metabolic alkalosis. So both loop and thiazide diuretics lead to a metabolic alkalosis. The first way they do this is through volume contraction, like we just discussed. They activate the renin-angiotensin-aldosterone system, and that leads to an alkalosis. These two diuretics also cause the potassium level to get low, and when the potassium level gets low, that can lead to an alkalosis. And then in addition, they increase the sodium and water delivery to the distal nephron. And anytime you send more sodium to the distal nephron, you get more potassium and H plus secretion. It's easiest to understand this with a drawing. So in the collecting duct, you are resorbing sodium. You are pulling sodium out of the urine in exchange for potassium and hydrogen ions. Both of those are being secreted into the urine. So anytime a diuretic sends more sodium to the collecting duct, that results in more sodium getting absorbed and more potassium and H plus going out. Therefore, both loop and thiazide diuretics can lead to increased potassium and H plus secretion by this mechanism, and that's part of what contributes to the alkalosis from diuretics. There are two very rare congenital disorders called Bartter and Gittleman syndromes that look just like patients on diuretics. So in Bartter syndrome, children have dysfunction of the sodium-potassium 2-chloride pump in the ascending limb, and they get the same physiology as patients on loop diuretics, so they can develop a metabolic alkalosis. Children born with Gittleman syndrome have dysfunction of the sodium chloride transport in the distal tubule, so they behave just like patients on a thiazide diuretic. So both of these disorders can cause hypokalemia and a metabolic alkalosis. These are very rare, and if you see it in a board question, it's going to be a child who has physiology similar to an adult who's taking one of these two diuretics. Vomiting is another mechanism by which you can develop a metabolic alkalosis. This occurs for a couple of reasons. First of all, you lose volume when you vomit, so this can lead to a contraction alkalosis. In addition, you lose hydrogen chloride when you vomit, so you lose hydrogen atoms, and then the body increases its production of hydrogen chloride, and this leads to increased bicarb generation during production. You also lose potassium when you vomit, so patients who are vomiting can be hypokalemic. And then a very important thing to know is that the urinary chloride gets low when patients are vomiting. Measurement of the urinary chloride level is a diagnostic test that is sometimes useful in metabolic alkalosis due to an unknown cause. The reason it can be a useful measurement is because the urinary chloride level will be low, which is less than 10 to 20 in patients who are vomiting. The reason it's low in this setting is because there is loss of chloride in gastric secretions. The urinary chloride level is high in many other causes of alkalosis. Thus, this is helpful for making a diagnosis of vomiting as a cause of metabolic alkalosis. And the classic scenario where this is useful that you should be aware of for your board exams is a young woman who has an unexplained metabolic alkalosis and the urinary chloride level is low. The diagnosis in this situation is usually surreptitious vomiting, often related to some type of eating disorder. And the way you make the diagnosis is by identifying the metabolic alkalosis and then identifying that the urinary chloride level is low. The word surreptitious, if you don't know, means secret, and just like patients can engage in surreptitious or secret vomiting, they can also sometimes engage in the surreptitious use of diuretics. This is sometimes done in order to lose weight or to eliminate edema. And as we talked about earlier, diuretics can lead to a metabolic alkalosis. In the setting of the surreptitious use of diuretics, the urinary chloride level can vary widely. Initially, after patients take a diuretic, their urinary chloride level becomes high. That's because diuretics inhibit the reabsorption of sodium and chloride, and thus there will be more chloride in the urine. However, these patients often take the diuretics intermittently, and when they stop taking them, the urinary chloride level falls to low levels and the effects of the diuretic begin to wane. So the key test in this setting in order to make the diagnosis of surreptitious use of diuretics is a diuretic screen. There are tests for the presence of diuretics and diuretic metabolites in the urine, and that can be employed in order to make the diagnosis of surreptitious diuretic use. Hyperaldosteronism can cause metabolic alkalosis. This happens when the adrenal gland overproduces aldosterone. This can either happen from generalized adrenal hyperplasia or from an adenoma that produces aldosterone. That's called Conn syndrome. And when you have this, the aldosterone does what it's supposed to do, but at an excessive level, so you get too much potassium and hydrogen ion secretion in the urine. The result is hypokalemia and a metabolic alkalosis, and these patients often have resistant hypertension. And if you see resistant hypertension in the setting of a low potassium, one of the first things you should think of is that there may be a hyperaldo state. Now, you might think that patients with high aldosterone levels would have evidence of fluid overload. For example, they would have edema in their lower extremities and elevated jugular venous pressure. However, often there is no edema in patients with hyperaldosteronism, and that is because of a phenomenon known as aldosterone escape. So initially, when the aldosterone level is elevated, sodium resorption and fluid retention occur, and this leads to hypertension. However, when this happens, compensatory mechanisms get activated. There are a number of these that have been described. One of them is an increase in the AMP level coming from the heart. But as a result of these compensatory mechanisms, what eventually develops is increased sodium and free water excretion. The result is a mild diuresis and a return to normal volume status. This also means that the urinary chloride level will be increased in patients who have hyperaldosteronism, and that's because of the increased sodium and free water excretion. Because of the aldosterone escape mechanism, it makes diagnosis of a hyperaldo state very difficult. These patients will have hypertension and won't have any other obvious signs of fluid retention, so you have to have a high degree of clinical suspicion, especially in a patient who has refractory hypertension and a low potassium level. And then the last cause of a metabolic alkalosis we'll discuss is antacid use, and this is called the milk alkali syndrome. So this happens when patients take in too much of calcium and some type of base. It's usually calcium carbonate and or milk. And this used to happen a lot before we had proton pump inhibitors. When patients had severe dyspepsia and stomach ulcers, they would take huge amounts of milk and calcium carbonate for dyspepsia, and they would get the milk alkali syndrome. So when you take all this calcium, you get hypercalcemia, and hypercalcemia has a couple effects that result in an alkalosis. First of all, they inhibit the sodium potassium chloride transporter in the thick ascending limb. This is the same thing that loop diuretics do. So this effect occurs from the hypercalcemia with antacid use. They also block the ADH-dependent water resorption in the collecting duct. So as a result of both of these effects, you get a volume contraction, which can cause an alkalosis. In addition to contraction, these patients are taking an alkali base, so the combined effect of those two things leads to a metabolic alkalosis. Years ago, patients would have severe hypercalcemia from the milk alkali syndrome and get very sick. In the modern era, this is usually picked up incidentally when blood work's done and it finds a mild hypercalcemia and a metabolic alkalosis from a patient who's taking a lot of antacids. On this slide, I've summarized the keys to diagnosis of the cause of a metabolic alkalosis. First of all, the patient's history is very important. Usually this reveals an obvious cause of metabolic alkalosis, such as vomiting or diuretic use. The fluid status is also very important. Patients who are volume depleted for any reason can develop a contraction alkalosis. For example, as we've talked about, this commonly occurs when patients have vomiting or other GI losses. And then lastly, I mentioned how the urinary chloride can be helpful a few slides ago. This is low in the case of surreptitious vomiting. And then finally, the treatment for almost all forms of metabolic alkalosis is simply to give IV fluid. Most forms of metabolic alkalosis are called fluid responsive. So patients who have a high bicarbonate level from diuretics or vomiting or any type of contraction alkalosis, they are going to get better if you give them IV normal saline. The exceptions are rare patients who have a hyperaldosterone state from an adrenal adenoma or patients who are severely hypokalemic, and that is causing the alkalosis. And that concludes our module on metabolic alkalosis.